Thank you. Thank you so much to everyone for taking time out of your day to join us. Again, my name is Lindsay Yoder. I am a PA at Indiana University in Indianapolis, Indiana. And today we are going to talk about comparing advanced F3 and F4 cirrhosis. So we're going to start with a case. This is a patient named Sam, who is a 55-year-old Caucasian gentleman who was referred for mildly abnormal liver enzyme labs. He'd already had an abdomen ultrasound showing increased liver echogenicity, and his main complaint is fatigue. We can also see his BMI is 33, so he's a bit overweight. His medical history includes type 2 diabetes, hypertension, hyperlipidemia, sleep apnea, fortunately, no alcohol use. Physical exam shows central abdomen adiposity, no stigmata of advanced liver disease, so I'm assuming no spider nevi, no hepatosplenomegaly. And then you can see his medications there, some antihypertensives, hyperlipidemia, and his diabetes medications. So he is still a little hypertensive, but his vitals are otherwise there. You can see the mild hepatocellular pattern of liver enzyme elevation with his ALT of 85, AST of 72. His ALK phos is normal, Billy just a tad elevated. And then his platelets are the lower end of normal, and his A1C is just a bit higher than we would like at 7.1%. Fortunately, he has preserved synthetic liver function with a normal INR. His ferritin is a bit elevated, iron saturation. Neither one of those ferritin or iron sats are making me necessarily concerned about hereditary hemochromatosis, probably secondary acute phase reactants. His ANA is slightly reactive, and then his smooth muscle and viral hepatitis screening is all negative. So when we are thinking about hepatic fibrosis assessment for this gentleman, when you calculate his Fib4, it is 3.1. So he is right in that intermediate category where Fib4 of 1.45 to 3.25 is going to predict an intermediate risk of advanced fibrosis. Then we have him undergo vibration-controlled transient elastography, and his FibroScan liver stiffness measurement is 11. Again, that's in that range, predicting significant, F2 to F3 fibrosis. And then his CAP score was 262. So there is some hepatic steatosis there, which we saw on the ultrasound as well. And then we have him get an enhanced liver fibrosis serologic blood-based biomarker test, and that ELF is 9.9. So it is positive. And so the first question is there any further testing we'd like to perform on this patient? Again, I think it's optional to serologically ensure you have ruled out hereditary hemochromatosis by potentially considering getting an HFE genetic mutation because of that ferritin and slight iron saturation. Because the ANA was weakly reactive, again, I don't have a high concern that this patient has autoimmune hepatitis, but if it makes you feel better to get an IgG and take a look at that, you could. As far as any further tests to try to distinguish between, F3 versus F4 fibrosis, I think we have every test that we need between an ultrasound that was not showing a nodular liver contour, and then the vibration-controlled transient elastography, LSM, the Fib4, the ELF, all of those other labs, the normal platelet count. So I would stage this patient as likely an advanced fibrosis F3, but there is nothing in any of the clinical, radiographic, or serologic picture of these results that we have that are making me concerned that this patient has cirrhosis. And then how would I treat this patient? I guess I should say I would also get a PEth for this patient. So any patient who has hepatic steatosis, although his history He denied significant alcohol use. We tend to confirm that. So I would want to confirm with a PEth that this is not someone who has alcohol-associated liver disease or MASLD. So presuming his PEth is negative or very low, then this is a gentleman with MASLD, presumed MASH, based on the presence of the advanced fibrosis, and I would counsel him on diet and lifestyle modifications. We would also want to bring in some multidisciplinary care with his endocrinologist or primary care and cardiologist, and ensure that his A1C hopefully gets down just a little bit lower, under 7%. We didn't actually see what his lipids were, but we know he's on lipid lowering therapy. So making sure that his total cholesterol, triglycerides, LDL, HDL are at goal. Those would be important features. And then again, working with primary care or a medically supervised weight loss on weight loss. All of these pieces of the diet and lifestyle would be helpful. And then this is someone who could qualify for treatment with Resmetirom, since he appears to have F3 advanced fibrosis, but not yet cirrhosis. And as far as monitoring this patient, if I was going to initiate him on Resmetirom from the get-go, then we would repeat a hepatic panel for him in 3 months. Our hepatology nurses call patients after we initiate Resmetirom in 2 weeks to check for any side effects and mitigate side effects if there are any. And then I would see him back in 6 months, and I would be repeating liver enzymes. I would get TSH, again, checking in on all of those other metabolic syndrome labs to see how well controlled things are. I'd be interested in repeating the vital signs to check in on his weight and if he's had any success with weight loss with diet and lifestyle changes, and go from there. If we did not initiate Resmetirom from the beginning right now in this patient, and he says he'd prefer to start with some diet and lifestyle modifications before being treated with a medication, because oftentimes that is something that the patients want to do, I would still then be seeing him back in 3 to 6 months and really keeping a close eye on his success with the diet and lifestyle modifications, so we know that we don't let too much time pass by before we need to continue to offer other tools in our toolbox for him. I would wait a year before I would repeat some of the things like FibroScan, ELF, in terms of trying to assess any improvements in fibrosis, just to give enough time to truly see a difference in those. So here we are, starting Resmetirom, lifestyle modifications, considering a GLP-1 that can really help with the weight loss. And, you know, there is some pretty good data coming out about those actually helping with hepatic fibrosis, reducing inflammation and steatosis as well. And then, you know, it is an option in someone with advanced F3 from presumed MASH to monitor for HCC. Certainly, if he had cirrhosis, we would be doing that. And so now we're going to think about the same patient. Couple things are a little bit different. So this is a 55-year-old Caucasian man, same BMI, 33. He has the same medical history: diabetes, hypertension, hyperlipidemia, sleep apnea, denies alcohol use, same physical exam, same medications, same set of vitals, same lab profile, with the exception that his Billy is a little bit more elevated at 1.4. But then here, a key difference is now he has thrombocytopenia. His platelet count has dropped below the threshold of normal, and it's 128,000. Everything else lab-wise there appears to be the same. So that thrombocytopenia is going to change his non-invasive testing scores. So when you calculate the FIB4, he still has the same FIB4, 3.11, with that intermediate risk of advanced fibrosis. Now, when we do his vibration-controlled transient elastography via FibroScan, his liver stiffness measurement is higher. It's 21 kilopascals. For me, over 20, highly suggestive of cirrhosis. His CAP score is 245, so this could be burnt out MASH cirrhosis, right? And then his ELF blood test is much higher. It's 11.4, much more in that sort of like slam dunk, highly predictive of F4 or cirrhosis. As far as further testing, again, if this didn't particularly mention if this gentleman had cross-sectional or ultrasound imaging. I am not sure if I'm to assume he had that same ultrasound, but this is someone who I definitely want to look at their entire abdomen. So an ultrasound abdomen complete, so I could assess for splenomegaly, collateral blood vessels, nodular liver contour, because this is someone who I'm predicting that I'm going to find those things. Could also do a CT scan or MRI of the abdomen for that same reason. And then staging this patient, this to me, his non-invasive testing and the thrombocytopenia, very consistent with presumed cirrhosis. And so treating this patient, I would not start Resmetirom in this individual since I am concerned he has cirrhosis and Resmetirom is not approved to treat patients with F4 cirrhosis. Really, this is going to be even more aggressive in the diet and the lifestyle modifications. So everything I said before, but presuming that this is compensated cirrhosis from MASH, I would be as aggressive as I can with him on the weight loss side of things. So again, considering a GLP-1 starting, getting him linked up with medical weight loss and really trying to move that BMI down, keeping in mind that I don't want him to lose so much weight that he gets muscle mass loss and sarcopenia and the complications that come along with that. So a really good medically supervised weight loss program that can focus on maintaining lean muscle mass while still losing weight and improving that BMI profile, and then focusing on optimal care of all of those metabolic syndrome features as well. And I would monitor him the same. Additionally, since he has cirrhosis, we need to consider endoscopy for variceal screening, certainly need to consider hepatoma screening if he had not already had ultrasound, CT, MRI for hepatoma screening. And then his MELD would be quite low. So this is not someone who I'd be thinking about liver transplant. I do happen to be at a tertiary liver transplant center here at Indiana University. So if that's something that he needed, he would already be in the right place. And so I agree with this diet, lifestyle, monitoring for liver cancer, screening for EGD. And so the big difference here between these two patients, their FIB4 score is the same. The ELF is different enough that it matters. And for me, really, the liver stiffness measurement is different enough, as well as the thrombocytopenia. Both of these patients had the similar ALT, AST. And usually what we'll see in someone with cirrhosis is an AST that's slightly higher. So not in that 2-to-1 ratio, the way you think about with alcohol. But by the time someone has advanced to having F4 cirrhosis, typically their AST is a little bit higher than their ALT. So that is another sort of non-invasive serologic marker that you can look at. It didn't happen to be true for this case study, but just something else from real world experience. So again, the difference in management here is our patient with advanced F3 fibrosis would be a candidate for Resmetirom, whereas the gentleman with cirrhosis would not. And for me, between the non-invasive tests, the liver stiffness measurement on the FibroScan tends to be the most important. The caveat being your patients that have pretty extreme central abdomen adiposity, sometimes that increased skin to liver capsule distance can falsely increase and elevate that LSM. And so I use that in combination with all of the other things, the ELF test, the platelet count, imaging that's showing either smooth contour or nodular contour, splenomegaly or not. And then really thrombocytopenia is one of the most important, non-invasive data points for me that helps me differentiate between someone with cirrhosis. And then if you have indeterminate non-invasive tests, this is where your liver biopsy still comes into play and oftentimes has to be sort of the tiebreaker where histologically you need that evidence and that data to say truly, F3 or F4 if your non-invasive tests are incongruent. And then certainly HCC surveillance is important in anyone with cirrhosis. So thank you so much, everyone, again, for taking time out of your day to join us for this GAP MASLD MASH Community Network chat about thinking about patients distinguishing between advanced F3 bridging fibrosis and F4 cirrhosis.